Hello, everyone, and welcome back to WoundCasters by Wound Care Today, where we explore the gaps by exploring the truth. I'm your host, Felix Boecker, and today we are tackling one of the most persistent and problematic myths in wound care: the idea that wounds need to breathe or be aired out to heal properly. But before we begin, don't forget that you can reach out to us through our website at wct-us.com and also find tons and tons of educational material on the website while you're there. Now, you've heard it from patients, you've probably heard it from family members, and if you've been in healthcare long enough, you might have even heard it from other healthcare providers. Just let it air out. It needs to dry out to heal. Take the bandage off and let it get some air. It sounds reasonable, doesn't it? Wounds are wet, and wetness seems bad, so drying them out must be good. Fresh air is healthy, so exposing wounds to air must help them heal. The logic seems intuitive. It's been passed down through generations, and it's almost completely wrong. So, let's explore where this myth came from, why it persists, and what the science actually tells us about wound healing environments, and whether there are any situations, any at all, where exposing a wound to air might actually be beneficial. Now, spoiler alert, for the vast majority of wounds, especially chronic wounds, leaving them open to air is one of the worst things you can do. But let's explore why, and let's understand the nuances, because as with everything in medicine, the answer is rarely, never, or always. Let's dive in. Let me start with a story that probably sounds familiar. I was seeing a patient with a venous leg ulcer. This was a woman in her 70s. The ulcer had been present for several months. When I arrived, her leg was completely exposed. No dressing, no bandage, nothing. The wound was dry, crusty around the edges, and looked terrible. I asked, "Where's your dressing?" She looked at me like I was the one who didn't understand wound care. "Oh, honey," she said, "I take it off during the day to let it air out. My mother always said wounds need to breathe. You can't heal if you keep it covered all the time. It needs oxygen." And there it was, a deeply held belief, passed down from her mother, probably passed down from her grandmother, that wounds need exposure to air to heal. This wasn't ignorance or neglect. This was what she truly believed to be proper wound care. So, where did this idea come from? To understand that, we need to go back in history, way back. For most of human history, we didn't have modern wound dressings. We didn't have gauze, adhesive bandages, foam dressings, hydrocolloids, or any of the sophisticated materials we use today. What we had was cloth, sometimes plant materials, and oftentimes nothing at all. In ancient and medieval medicine, wounds were frequently left exposed. Sometimes they were covered with rudimentary bandages, but these were often removed regularly to check the wound, and there was a general sense that wounds needed to be exposed to air. Part of this came from the theory of laudable pus, the idea that pus formation was a necessary and positive part of healing. Physicians would actually try to promote suppuration. The wound was kept open, sometimes deliberately irrigated to produce more pus, because pus was thought to be the body's way of healing. Now, we now know this was completely backwards. Pus is a sign of infection and not healthy healing, but this belief persisted for centuries. And if you believed pus was good, then keeping wounds open to allow drainage made sense in that framework. Then came the miasma theory of disease, the idea that disease was caused by bad air or noxious vapors. In this model, fresh air was seen as healthy and stagnant air was seen as dangerous. By extension, keeping a wound covered was thought to trap bad air and promote disease, while exposing it to fresh air would be protective. Again, we now know this is wrong. Disease is caused by pathogens, not bad air, but you can see how these historical beliefs created a cultural framework where air exposure seemed beneficial. Moving forward to the 19th and 20th centuries, we start to see a shift. Joseph Lister introduced antiseptic technique in the 1860s, which revolutionized surgery and wound care. Suddenly, we understood that infection came from living organisms and not bad air. We started sterilizing instruments and using antiseptic solutions. But even in the Lister era, wounds were often kept relatively dry. Dressings were changed frequently, and there was still a sense that wounds should not be kept too moist. Part of this was practical. Moist dressings in the pre-antibiotic era could be breeding grounds for bacteria. The idea of scab formation as healthy healing became entrenched. Everyone had the experience of getting a cut, leaving it open, forming a scab, and the wound healing underneath. This seemed to confirm that drying out was part of normal healing. And for small, superficial, acute wounds, this observation wasn't entirely wrong. Scabs do form part of the healing process for minor injuries. The problem is generalizing this observation to all wounds, including large, deep, and chronic wounds where the dynamics are completely different. Now, let's fast forward to the Revolution, George Winter's work in the 1960s. Winter was a British researcher who conducted experiments on pigs, still considered a landmark study in wound care. He created partial thickness wounds and covered half of them with occlusive dressings while leaving the other half exposed to air. The results were striking. Wounds kept moist under occlusive dressings re-epithelialized twice as fast as wounds left exposed to air. Twice as fast. This wasn't a marginal difference. This was a fundamental difference in healing rates. His work showed that maintaining a moist wound environment facilitated cell migration, prevented tissue desiccation, and promoted faster healing. This should have ended the debate right there. And in professional wound care, it largely did. His work, along with subsequent research throughout the 60s and 70s, established the principle of moist wound healing as the foundation of modern wound care. By the 80s and 90s, the entire advanced wound dressing industry was built on this principle, creating products that maintain optimal moisture balance. But here's the disconnect. While professional wound care moved toward moist wound healing, the general public and even some healthcare providers never got the memo. The old belief that wounds needed to air out persisted as folk wisdom. Why did this myth persist despite the science? I think there are several reasons. First, personal experience. Everyone has had small cuts and scrapes that healed fine while exposed to air. That experiential evidence is powerful, even though it doesn't generalize to larger or chronic wounds. Second, the ick factor. Wounds covered by moist dressings can look worse initially, and they might have more drainage, might look wetter and more unpleasant. To the untrained eye, this looks wrong, even though it's actually promoting healing. Third, misunderstanding of infection risk. People reasoned that keeping a wound covered creates a closed environment where bacteria can grow, while exposing it to air would somehow prevent bacterial growth. This is backwards. Air exposure doesn't sterilize a wound, and proper dressings actually provide a barrier to environmental contamination. Fourth, the language we use. We talk about occlusive and semi-occlusive dressings, which can sound problematic. We say wounds need to breathe, which creates a misleading mental model. Wounds don't actually breathe. They don't need atmospheric oxygen exposure for cellular respiration. Oxygen reaches tissue through blood flow, not through air exposure. Fifth, inadequate patient education. How many times have we sent a patient home with a dressing and instructions to keep it clean and dry without explaining the why? How often do we fail to explain that the dressing serves a purpose beyond just covering the wound? We haven't done enough to educate patients and families about the science of wound healing. And sixth, frankly, some healthcare providers perpetuate the myth. I've heard nurses, physicians, and other providers tell patients to let it air out or remove the dressing for a few hours each day. Sometimes this comes from their own misconceptions, sometimes from outdated training, and sometimes from a desire to tell patients what they expect to hear. So here we are, more than 60 years after Winter's landmark study, with an entire industry built around maintaining moist wound environments, with mountains of evidence supporting this approach, and yet I still regularly encounter patients who are sabotaging their wound healing by removing dressings to let the wound breathe. The gap between evidence and practice, between professional knowledge and public understanding, has real consequences for wound healing. And that's what we need to address. So let's dig into the actual science. What happens at the cellular and molecular level when a wound is kept moist versus when it's allowed to dry out? Understanding this will help you explain to patients and skeptical colleagues why moist wound healing isn't just preferred, it's physiologically superior. Let's start with what happens in an optimal moist wound environment. When a wound is maintained in a moist environment, several beneficial processes occur. First, cell migration. The cells that close wounds, keratinocytes from the wound edges, need to migrate across the wound surface. This process, called epithelialization or re-epithelialization, happens much faster in a moist environment. Why? Because cells can glide across a moist surface. In a dry environment, keratinocytes have to burrow underneath dead and desiccated tissues. It's like the difference between ice skating on smooth ice versus trying to skate through gravel. Studies have shown that epithelialization can be 30 to 50% faster in moist environments compared to dry environments. That's not marginal. That's clinically significant. Second, autolytic debridement. In a moist wound environment, the body's own enzymes, proteases and collagenases, can break down dead tissue and debris. This is autolytic debridement, the body cleaning itself. The enzymes need moisture to function. When a wound dries out, autolytic debridement stops, and necrotic tissue remains in the wound, impeding healing. Remember, we are a water-based organism. Our body's chemistry depends on water primarily. No water, no chemistry. No chemistry, no healing. Third, growth factor activity. Growth factors, the signaling molecules that orchestrate wound healing, are mostly active in aqueous environments. They need moisture to diffuse through tissue, bind to receptors, and exert their effects. A desiccated wound environment disrupts growth factor signaling. Fourth, optimal inflammation. A moist environment supports appropriate inflammatory responses without excessive inflammation that can damage tissue. Dry wounds tend to have more prolonged and intense inflammation, which can actually impede healing. Fifth, less pain. This is patient-centered but important. Dried out wounds, especially with adherent dressings or eschar, are more painful. Nerve endings are exposed and irritated. Moist wound healing is generally more comfortable for patients. Sixth, less scarring. Wounds that heal in a moist environment tend to produce better cosmetic outcomes with less scarring. The re-epithelialization is more organized and there is less disruption of the healing process. Now, let's talk about what happens when you expose a wound to air and let it dry out. First, desiccation of tissue. The wound surface dries, cells die, and you form a layer of necrotic tissue. For small superficial wounds, this becomes a scab. For larger wounds, this becomes eschar, a thick, leathery layer of dead tissue. That scab or eschar might seem protective, but it can actually be a barrier to healing. Keratinocytes have to migrate underneath it. If it's thick enough, the wound can't epithelialize until the eschar separates, which can take weeks. Second, cell death at the wound margins. When the wound surface desiccates, cells at the wound edges die. The wound effectively gets deeper and wider because you're losing viable tissue to desiccation. Then, those dead cells need to be cleared before healing can proceed, which delays everything. Third, disruption of the moisture gradient. Wounds naturally have a moisture gradient, moist at the base where new tissue is forming and gradually less moist toward the surface. Maintaining this gradient is important for optimal healing. Excessive drying disrupts this gradient. Fourth, increased infection risk. Now, this might seem counterintuitive. Doesn't keeping wounds covered increase infection risk? No. Studies consistently show that properly covered wounds have lower infection rates than exposed wounds. Why is that? Because dressings provide a physical barrier to environmental contamination. An exposed wound is constantly being exposed to bacteria from the air, from clothing, from contact with surfaces. A properly covered wound is protected. Also, dry necrotic tissue is actually a good medium for bacterial growth. The bioburden in dried out wounds can be significant. Fifth, pain. Exposed nerve endings, desiccated tissue, and adherent scabs or dressings are all painful. Patients with exposed wounds often report more pain than those with properly managed moist wound healing. Sixth, increased scarring. Wounds that heal while dry, with repeated cycles of scab formation and separation, tend to have more disorganized healing and worse cosmetic outcomes. Let's address the oxygen question directly because this is a major source of confusion. Don't wounds need oxygen to heal? Absolutely. Oxygen is critical for wound healing. Cellular respiration, collagen synthesis, angiogenesis, and bacterial killing by neutrophils all require oxygen. But here's the key. Wounds get oxygen from blood flow, not from air exposure. Oxygen is delivered to tissues via hemoglobin and red blood cells through capillaries. The partial pressure of oxygen in well-perfused tissue is what matters, not whether the wound surface is exposed to atmospheric oxygen. In fact, there's an interesting paradox. The wound healing environment is actually somewhat hypoxic, lower oxygen than normal tissues, and this hypoxia triggers important healing responses like VEGF production, which drives angiogenesis. So mild tissue hypoxia is actually a signal that promotes healing. The idea that exposing a wound to air gives it oxygen is based on a fundamental misunderstanding of physiology. Air exposure doesn't meaningfully increase tissue oxygenation. What increases tissue oxygenation is adequate perfusion, good blood flow to the wound. This is why addressing vascular disease is so critical in wound healing. You could expose a wound to pure oxygen at high pressure, which is essentially what hyperbaric oxygen therapy does. And it will only help if you have blood flow to deliver that oxygen to the tissues. All right, let's talk about moisture balance because this is where the nuance comes in. When we say moist wound healing, we don't mean wet or macerated. We mean optimal moisture balance. Too dry means cell desiccation, impaired migration, eschar formation, which are all bad for healing. With optimal moisture, cells can migrate, autolytic debridement occurs, growth factors function, tissue remains viable, all good for healing. If it's too wet, maceration of surrounding skin, bacterial overgrowth, breakdown of peri-wound tissues, also bad for healing. The art of wound care is maintaining that optimal moisture balance, which is what modern wound dressings are designed to do. Different dressings manage moisture differently. Hydrocolloids maintain moisture and absorb minimal exudate. Foams absorb moderate to heavy exudate while maintaining a moist interface. Alginates and hydrofibers absorb heavy exudates. Hydrogels donate moisture to dry wounds. And films maintain moisture, allow moisture vapor transmission through the film. The choice depends on the wound's characteristics. A heavily exudating wound needs an absorptive dressing. A dry wound needs moisture donation. But neither extreme, too dry or too wet, is optimal. This science is not controversial among wound care experts. Moist wound healing is an established principle in wound care. The controversy only exists in the gap between professional knowledge and public understanding. So when patients tell you they're removing dressings to let the wound breathe, you can explain with confidence that they're working against their own healing. And you can explain why, not just tell them that's not how we do it. Let's get specific about the harms that come from exposing wounds to air, especially chronic wounds, because understanding the actual harm helps us understand why this isn't just a preference issue, this is a patient safety issue. Let me start with a case that illustrates multiple problems. I had a patient with a diabetic foot ulcer on the plantar surface right under the first metatarsal head, classic location. The ulcer was about 2 centimeters in diameter, full thickness down to tendon. We started standard care, offloading, regular sharp debridement, infection management, glucose optimization, moisture balance dressings, and after 2 weeks, the wound looked worse. The wound bed was dry, had increased necrotic tissue, and the wound had actually gotten larger. So I asked the patient about compliance with our plan of care. He said he was doing it all. I asked about the dressing changes, and that's when he told me, "Oh, I take the dressings off when I go to bed at night. I let it air out. My friend told me that it helps dry out and prevents infection." So, let me count the ways this was causing harm. Number 1, tissue desiccation and cell death. Every night for 8 hours, the wound surface was drying out. Cells at the wound margins were dying. The wound was getting deeper and wider, not because of the underlying pathology, but because we were iatrogenically killing tissue. Number 2, necrotic tissue accumulation. Without a moist environment, autolytic debridement wasn't happening. The necrotic tissue we were carefully debriding during our clinic visits was reaccumulating because the body couldn't clear it on its own. Number 3, impaired epithelialization. Whatever epithelial migration might have occurred during the day under the dressing was being reversed at night when the wound dried out. We were essentially taking one step forward and one step back every 24 hours. Number 4, increased infection risk. Despite the belief that air exposure prevents infection, this patient developed a wound infection that required antibiotics. The exposed wound was contaminated from the sheets, from ambient bacteria in the bedroom, from everything the foot contacted overnight. And number 5, delayed healing. What should have been a 6 or 8 week healing course turned into 14 weeks or more because we spent the first month basically spinning our wheels while the patient unknowingly sabotaged his healing every night. Once we educated him properly, and I mean really educated him, explaining the science, showing him diagrams of cell migration, discussing why moist wound healing works, and he kept the dressings on continuously with a total contact cast, the wound started healing appropriately. Same patient, same ulcer, same treatment, except for one change: keeping it properly covered. Let's talk about contamination more specifically, because this is a major concern with exposed wounds. Patients often believe that keeping a wound covered creates a dirty environment while exposure to air keeps it clean. This is exactly backwards. The environment we live in is not sterile. The air contains bacteria, fungi, dust particles, allergens, and pollutants. Surfaces we contact, clothing, furniture, bedding, are covered in microorganisms. These are generally harmless to intact skin, but a wound is a portal of entry. When you expose a wound to the environment, you're exposing it to constant bacterial contamination. Every air current, every touch, every contact with clothing or surfaces deposits bacteria into the wound. Modern wound dressings, on the other hand, provide a bacterial barrier. They're designed to be impermeable to bacteria while managing moisture. This protects the wound from environmental contamination while maintaining the optimal healing environment. And there's good evidence for this. Studies comparing infection rates in covered versus uncovered surgical wounds consistently show lower infection rates in covered wounds. The same principle applies to chronic wounds. I've seen chronic wounds develop infections directly attributable to inadequate coverage. Venous leg ulcers that patients leave uncovered while sitting in their living rooms. Pressure injuries that patients insist on airing out for hours each day. These wounds developed increased bioburden, progress to clinical infection, and require antibiotics that might have been avoided with proper coverage. So let's talk about specific wound types and the specific harms of air exposure. For venous leg ulcers, these wounds are typically highly exudating. When you remove the dressing and expose them to air, several things happen. The exudate dries on the wound surface and surrounding skin, creating a crusty, uncomfortable mess. The peri-wound skin, already compromised by chronic venous insufficiency, becomes more macerated and more dry and cracked, and depending on the pattern of exudate and drying, the wound bed desiccates between episodes of exudate production. And the patient is at higher risk of contact dermatitis from the dried exudate on the skin. The proper approach is an absorptive dressing that manages the exudate while maintaining a moist wound interface, changed at appropriate intervals with compression therapy on top. For diabetic foot ulcers, as in the case I described, desiccation leads to tissue death, necrotic tissue accumulation, impaired healing, and increased infection risk. There's an additional concern. With neuropathy, patients often don't feel when the wound is being contaminated or irritated. They might walk on an exposed wound, grind dirt and debris into it, and not realize anything is wrong until they develop a serious infection. Diabetic foot ulcers need to be covered continuously, protected from contamination, and kept in an environment that promotes granulation and epithelialization. For pressure injuries, these wounds often have undermining and tunneling, and when you expose them to air, only the surface dries out. The deeper parts of the wound might retain moisture, creating a situation where the surface is desiccated, but the deeper wound is poorly managed. This creates a problem with healing. it creates a more complex problem, to be honest. Pressure injuries need dressings that can manage the three-dimensional nature of the wound, prevent desiccation, support autolytic debridement, and protect it from contamination. For surgical wounds and dehiscences, these wounds typically have clean, healthy tissue if they're dehiscing for mechanical reasons rather than infection, that is, and exposing them to air desiccates the tissues that you're trying to keep viable for eventual closure. It increases infection risk in a wound that might have been clean. And it makes eventual closure, whether by delayed primary closure or by secondary intention, more difficult because you have now added more necrotic tissue that needs to be managed. Here's another harm that's less often discussed: the psychological and social impact of exposed wounds. Wounds that are properly covered are less visible, less odorous, and are less likely to cause embarrassment or social isolation. Patients with exposed, draining wounds often feel self-conscious, avoid social situations, and experience reduced quality of life. I have had patients tell me they stopped visiting family and stopped going to church, stopped participating in activities they love because they were embarrassed about the wound drainage and odor. Proper dressings that manage exudate and odor while promoting healing improve not just the wound, but the patient's entire quality of life. The bottom line on harm: exposing wounds to air isn't benign. It's not a neutral choice. It actively impedes healing. It increases complication risks and negatively impacts patient lives. This is why we need to be proactive in educating patients against this practice. Now, I promised nuance, and here's where it comes in. Are there any situations where exposing a wound to air might be appropriate or even beneficial? I have spent most of this episode so far arguing against air exposure, but let's examine whether there are any exceptions. The short answer is yes. There are a few specific situations where temporary air exposure might be reasonable. But these are the exceptions, not the rule, and they're more limited than what most people think. We're talking about minor abrasions, superficial scratches, small paper cuts, wounds that are millimeters deep, minimal tissue loss, and occur in people with normal healing capacity. For these wounds, the natural process of scab formation and healing under a scab works just fine. Does keeping these wounds covered with a bandage help? Yes, actually. Studies show even these minor wounds heal significantly faster when covered. But the difference is small enough that many people don't bother, and that's not unreasonable. However, and this is important, even for these minor wounds, if they are in a location that is frequently contaminated, think hands and feet, or subjected to repeated trauma, covering them is better practice. When you're doing a dressing change, you remove the old dressing, you clean the wound, and then there's a brief period, we're talking minutes, right, before you apply the new dressing. During those minutes, the wound is exposed to air, and that's fine. That's necessary for wound assessment and dressing application. What's not fine is saying, let's leave the dressing off for a few hours to let it air out between dressing changes. That's when you get desiccation and problems. So yes, transient air exposure during wound care procedures is unavoidable and not harmful. Prolonged intentional air exposure, now that's a different story. If you have an abscess or an infected wound that needs to drain, you might initially leave it loosely packed or with drainage in place rather than completely occluding it. The goal is to allow fluid to escape while preventing premature closure. But even here, we're not really talking about airing out. We're talking about managing drainage with appropriate materials, right? Gauze packing, drains, dressings that allow fluid passage, not just leaving the wound completely exposed. And once drainage has decreased and infection is controlled, you transition to a moisture-balanced dressing that promotes healing. Here's one that might surprise you. If you have an arterial ulcer with dry gangrene, tissue that's mummified, leathery, and completely desiccated, sometimes the approach is to keep it dry until revascularization can be performed. Why? Because if you add moisture to dry gangrene without adequate blood flow, you can convert it to wet gangrene, which is a surgical emergency. The dry, mummified tissue is relatively stable. Once you restore blood flow, then you can aggressively debride and manage the wound with moisture balance. This is a very specific scenario, requires careful clinical judgment, and doesn't apply to moist wounds. Now, after certain toenail procedures, especially partial nail avulsions with chemical matrixectomy, the practice is sometimes to leave the area open to air after the initial post-op period. The chemical used, which is usually phenol, creates a controlled burn that needs to remain relatively dry. But again, this is a specific situation to a particular procedure with particular post-op requirements, not a general principle applicable to all wounds. Now, let me tell you what's not an exception, because I've heard these cited as reasons to air out wounds. Not an exception. The wound is too wet or macerated, so I'm airing it out to let it dry. If a wound is overly moist or the peri-wound skin is macerated, the solution is not to remove all dressings and let everything desiccate. The solution is to use a more absorptive dressing, address the source of excess moisture, protect the peri-wound skin with barrier products, and reassess the dressing more frequently. Going from too wet to completely dry doesn't pass through optimal. It just swings from one harmful extreme to another. Also not an exception, the wound has an odor, so I'm airing it out. Wound odor usually indicates bacterial overgrowth or necrotic tissue. The solution is to address the underlying cause, debridement, antimicrobial dressings, systemic antibiotics if necessary, but removing the dressing and exposing the wound doesn't eliminate the odor. It just spreads the odor around and adds contamination to the problem. Modern dressings with activated charcoal can manage odor while maintaining appropriate moisture balance. Also not an exception. The wound looks worse under the dressing, so I'm taking it off. Sometimes, when you remove a dressing after a few days, the wound looks worse. More drainage, tissue looks more moist or different in appearance. And this doesn't mean the dressing is causing harm. It means the wound is in the process of healing and you're seeing the active wound healing environment. If the wound is truly deteriorating, increasing in size, increasing necrosis, signs of infection, then you need to change your wound management approach, not abandon dressings altogether. Also not an exception, it's itchy under the dressing. Itching under a dressing can indicate allergic reaction to the adhesive, sensitivity to a dressing component, or just the normal sensation of healing. The solution is to identify the cause. Maybe try hypoallergenic dressings, a different adhesive, address any contact dermatitis, and not to leave the wound uncovered. So here's my summary on exceptions. They exist, but they're rare and very specific. For the vast majority of wounds that you encounter in clinical practice, chronic wounds, surgical wounds, traumatic wounds, the answer to should I let this air out is no. And even in the exceptions I mentioned, we're usually talking about temporary, limited air exposure as part of a specific management strategy, not the general practice of regularly removing dressings to let the wound breathe. The default should always be proper coverage with appropriate moisture-balanced dressings. Deviations from that default require specific clinical justifications, not adherence to a myth. All right. So you understand the science. You know why moist wound healing is superior. You recognize the harms of air exposure, and you understand the rare exceptions. Now comes the hardest part, changing behavior. How do you educate patients and maybe even some colleagues out of a deeply held belief that's been passed down through generations? This is where communication skills matter as much as clinical knowledge. So let me give you some strategies. Strategy 1, start with validation and not correction. When a patient tells you they're airing out their wound because that's what their mother taught them, don't immediately say that's wrong. Instead, start with something like, I understand why you would think that. It's what a lot of people have been taught for generations. It makes intuitive sense that wounds need air, and for small cuts and scrapes like the kind we get as kids, that approach works okay. But what we've learned from research over the past 60 years is that larger wounds, especially chronic wounds like yours, actually heal much better when they're kept covered with the right kind of dressing. You're validating their belief as a reasonable given their information, but you're also introducing the idea that there's better information available. Strategy 2. Use clear and simple explanations of the science. Don't just tell patients, keep it covered. Explain why. You might say, the cells that close your wound need to crawl across the wound surface, kind of like how you might slide across a smooth floor. When the wound dries out, it's like trying to slide across gravel, much slower and harder. Keeping it moist with the right dressing lets those healing cells move faster. Or maybe your body has its own cleaning system that breaks down dead tissue, but it only works in a moist environment. When the wound dries out, that natural cleaning system stops working and dead tissue builds up instead of being cleared away. Simple analogies make the science accessible and memorable. Strategy 3, address the oxygen misconception directly. Many patients believe wounds need air exposure for oxygen. You need to tackle this one head on. I know it seems like wounds need to be exposed to air to get oxygen, but here's how it actually works. Oxygen gets to your wound through your blood, not through the air. The blood vessels bring oxygen-rich blood to the wound, and exposing the wound to air doesn't add any oxygen to the tissues. What matters is good blood flow. The dressing we're using doesn't block oxygen from reaching your wound. It protects it while letting your blood do its job. This directly counters the misconception with accurate physiology explained in plain language. All right, strategy 4, use visual aids. If you have access to images or diagrams showing moist wound healing versus dry wound healing, use them. Show patients what epithelial cells look like, how they migrate, what happens when tissues desiccate. Visual learning is powerful. You can also show patients photos, with appropriate consent, of course, of wounds that healed well with proper coverage versus wounds where healing was delayed by air exposure. Before and after images are compelling. Strategy 5, address infection concerns proactively. Many patients worry that keeping a wound covered will trap infection. Address this concern before they even voice it. I know some people worry that keeping a wound covered will cause infection, but actually the opposite is true. These dressings provide a barrier that protects your wound from bacteria in the air and from contact with surfaces. Studies show that properly covered wounds have fewer infections than wounds left exposed. The dressing isn't trapping infection, it's preventing it. Strategy 6, give them ownership of the process. Rather than just telling patients what to do, help them understand how to assess their wound care. You can tell if the dressing is working well by checking a few things. Is your pain getting better? Is the wound bed looking healthier, right? More pink, less yellow or gray. Is it getting smaller? If you're seeing those signs, the dressing is doing its job. If you take the dressing off to air it out, you'll slow down all of that progress. This gives patients the tools to see the results themselves, which reinforces the teaching. Strategy 7, address practical concerns. Sometimes patients remove dressings not because they believe in airing out, but because of practical issues: cost of dressings, difficulty changing them, discomfort, adhesive sensitivity. If you solve these practical problems, you remove the motivation to abandon proper wound care. Ask something like, is there anything about the dressing that's bothering you? Are you having trouble with the changes? Are you concerned about the cost? Then problem solve around those real barriers. Number 8, involve family members. Often, it's not just the patient who believes in airing out wounds, it's their spouse, their adult children, their friends. If family members are encouraging harmful practices, you need to educate them too. When possible, include family in your teaching sessions. Give them the same information, answer their questions, and help them become partners in proper wound care rather than saboteurs of it. Strategy number 9, use teach back. After explaining why wounds should stay covered, ask the patient to explain it back to you in their own words. Just to make sure I explained that clearly, can you tell me in your own words why we're keeping your wound covered? This ensures that they've actually understood and retained the information, and it gives you a chance to clarify any misconceptions. Finally, strategy number 10, follow up and reinforce. Education isn't a one-time event. Every visit, ask about the dressing. How are you managing the dressing at home? Are you keeping it on continuously? Reinforce the teaching. Celebrate when they're compliant. If they're still airing it out, revisit the education without judgment. Behavior change takes time and repetition. All right, let's wrap this up. The myth that wounds need to air out or breathe is one of the most pervasive and harmful misconceptions in wound care. It's based on outdated understanding, perpetuated by cultural beliefs and inadequate education, and it actively impedes wound healing. The science is clear. Wounds heal faster with less pain, fewer complications, and better outcomes when kept in an optimally moist environment with appropriate dressings. Air exposure leads to desiccation, cell death, delayed healing, and increased infection risk. The exceptions to this principle are rare and specific. For the vast majority of wounds, certainly for chronic wounds like diabetic ulcers, venous ulcers, and pressure injuries, continuous coverage with moisture-balanced dressings is the standard of care. Our job as wound care providers is twofold: provide excellent clinical care and educate our patients effectively. We can do everything right clinically, but if our patients go home and remove their dressings every night to let the wound breathe, we're fighting a losing battle. We need to invest time in patient education. We need to explain the why, not just the what. We need to address misconceptions directly and compassionately. And we need to equip our patients to be partners in their own wound healing, not inadvertent saboteurs of it. To the patients and families listening, I know this might contradict what you've always believed and what your grandmother taught you, but medicine evolves. What we thought was true 50 or 100 years ago has been replaced by better understanding. Trust the science. Trust your wound care team. Keep your wounds properly covered and give your body the best possible environment to heal. To my fellow wound care providers, don't assume patients understand why we use dressings. Invest the time to educate, combat the myths. And when you encounter colleagues who are perpetuating outdated practices, educate them too, gently but firmly. Thank you for spending this time with me exploring this important myth. Thank you for spending some time with us today and exploring this gap, exploring this truth. We want to hear your thoughts, comments, and reactions to this conversation, so please reach out. If there are any particular topics you want to hear about or guests you would like to see on the show, reach out and contact us. If you're listening to this on a podcast app, be sure to subscribe and leave us a 5-star review so others can find this content more easily. And if you like this particular episode, please share it with a friend. Also, don't forget to check out our website at wct-us.com for lots more educational content. And finally, be sure to tune in next time as we explore yet another aspect of the challenging and rewarding field of chronic wound care. Ciao.